This is MVIYF, Episode 3. Make a fertility plan. Having a fertility plan instead of cycling blind is really helpful. Psychologically it helps, but results-wise it also helps, and right from the start. The first episodes were all about starting the ball rolling, choosing the right fertility specialist and clinic. But that's only the first step. It's a big step. The first step is often the most difficult, especially if you've been a procrastinator on the personal front like me. I was so reticent to make the wrong decision, I avoided making one altogether. If you've seen the movie Failure to Launch, you'll get the picture. I was stalling on making personal plans. In the first episode, I recounted my first consult with a fertility specialist, which had us descend into a temporary chasm of utter despair. But it's not something you should put off for that reason. You need to hear the statistics from a professional, not just from a girlfriend. That is the only way you'll take your predicament seriously. I recommend making a big picture plan from the start, dealing with the big issues, the cycle working or not working, and potential fallbacks. By fallbacks, I just mean something you do if something doesn't work. I say potential for two reasons. One, any fallback may not be needed. You may get pregnant. Two, any fallback may be one that you're not 100% happy with, but it does get you thinking proactively, openly, and positively about options within your control. And that's what you're trying to do. Wrest back control to the extent you can and make good decisions. A fallback doesn't need to be anything drastic. It may simply be another cycle. IVF treatment is often changed to take account of your last cycle and how your body responded. For example, the drugs or the protocol, so how long you took the drugs for and when, might be changed if you had a poor response. You don't need to have the whole suite of fallbacks mapped out before you've done even one cycle, but you do need to keep a few steps ahead. Why? Planning helps psychologically, so you keep on track after a setback, and this betters your odds of success. If you have repeated cycle failures, it may be worthwhile looking at further fallbacks, some of which will likely be discussed by your doctor and some of which perhaps will not be. For example, you might actually want to consult with another doctor or clinic to get a second opinion. IVF is not the same across clinics and countries. There is no standard IVF protocol for all women in their 40s. And that's a good thing, just to digress for a minute. The sum of IVF knowledge will hopefully be increased if good data is collected across the globe on the effect of different protocols and drugs on success rates. Unfortunately, it also means sample sizes are often smaller because protocols are not standard across the globe. Patient dosages may also differ in that sample because it's done primarily for clinical, not research purposes. So the research is compromised by this, but is still useful. In Japan, mild stimulation became really popular, but success rates fell. So while taking less drugs sounds good, if you have to do 3 mild cycles to the previous 1 traditional to achieve the same success, that is really bad for a 40-year-old. She doesn't have that time. So evaluating your options doesn't mean just doing what sounds good to you as a layperson, but educating yourself on IVF by listening to the doctors who treat women in their 40s. One way to do that is to speak to a second fertility specialist who treats women in their 40s. That's unlikely to be canvassed at the clinic you're cycling at. Just getting a second opinion doesn't mean you have to proceed with that doctor. What you're trying to do is evaluate your options. Another option may be to change the goal. If you were doing successive freeze-only cycles because you wanted a number of embryos before transferring, you might decide to switch to implanting one of the frozen embryos if you're no longer responding to the IVF drugs. That fallback is simply changing the purpose of the cycle from freeze-only to implanting. These options need to be discussed with your fertility doctor. For how long you do IVF cycles depends on a lot of different factors. your doctor's advice, your finances, and your own personal mindset. At some point, if you have repeated cycle failures and your early 40s are behind you, it's probably time to look at other fallbacks. The options of fallbacks available depend on your doctor's view as to why your cycle is failing. The weak link, which is hampering your success. I deliberately use the word weak because I think everyone is so fearful of offending these days that the negative things are often skirted around and not addressed. Honesty is always best, especially as regards your fertility. The weak link may be your eggs, your partner's sperm, or your womb. The weak link may also be unknown. You might have heard of the phrase unexplained infertility. That could be the case where you have fairly good egg numbers, good sperm, good embryos, but no success. Something that cannot be pinpointed is preventing you from falling pregnant. And that may be an example of where a second opinion would be really useful. I'm sure doctors feel overly constrained by political correctness. They don't want someone lodging a complaint because their sensitivities were grossly offended when they mentioned using someone else's DNA. It's not casting aspersions on your DNA, it's just the reality of your predicament. So options do include donor eggs, donor sperm, or if carrying a baby is the issue, surrogacy. You might think it's unnecessary to plan this, but given the statistics, it's good to foreshadow what may happen. So to recap, your big picture plan might be something like 3 cycles initially. That's just a number I picked randomly. Then if you get embryos in those 3 cycles, even if they don't survive to day 5 or do survive but don't implant, you have a good picture of your response to the IVF drugs, and that's encouraging. So your first fallback may be to do a few more cycles, because the good thing is you're actually retrieving eggs. You can do those cycles at the same clinic if you're happy with that clinic, or switch to another clinic. Obviously, switching clinics is unlikely to be recommended by your clinic. Just like your individual cycle is not the same each time, IVF treatment is not the same at every clinic and is not the same in every country. So a fallback may be getting a second opinion. Your specialist may also recommend switching drugs or IVF protocols or something else. If none of that works, the final fallback may be to use donor DNA for the eggs, sperm, or to use a surrogate if it's your womb that is the problem. That's a big picture plan. It obviously has to be a loose plan because every time you do a cycle, the results of the cycle provide more information. It's easy to stick your head in the sand and say you'll make it up as you go along because there are so many uncertainties. But a plan is a psychological buffer to setbacks. If you have a failed cycle, you don't know how you'll react to that news. Planning will help soften the blow and get you back on track. If doing a further cycle is in your plan, the sooner the better in terms of increasing your pregnancy odds. Back-to-back cycles may not be the ideal, but neither is doing IVF in your 40s. And even if you can't do another cycle, you don't want to fall into a huge depression because that will affect your personal well-being. Imagine if your plan was just 1 or 2 cycles because that's all you can afford. More than ever, you still need a plan because everything is riding on those 1 or 2 cycles, and you don't have the opportunity to do more cycles to increase your pregnancy odds. So researching the specialist and clinic is very important. You want to feel like you did your utmost. I guess I'm saying prepare for the worst and hope for the best so the worst is not as bad as it seems. If you plan, you feel like you have given things your best shot, taking account of your financial constraints, and you have that to be proud of. Planning for most patients probably brings to mind the detailed fertility plan in terms of your treatment logistics, your IVF protocol or your treatment plan, but that's your doctor's job, not yours. You can't control your response to the drugs or what the next scan will show in terms of follicle growth, but you can understand what you are doing to better your odds, and this will help you make the big picture fertility plan with fallbacks. You can understand what a successful IVF cycle looks like, even if your body's response is out of your control. IVF has a number of parts to it. You may not complete all the parts, but it helps to understand the big milestones so you know what to expect. You're not trying to get involved in the minutiae or preempt dosage increases in your IVF drugs. That would be ridiculous. You're not qualified and you're paying a specialist to do that for you. But knowing the milestones will give you the opportunity to discuss them with your specialist well ahead of time. Often you have a consult at the beginning of the cycle, and from then on, it is managed by your specialist team of nurses behind the scenes. And you might not see your specialist again until retrieval day. Even then, someone else may be standing in for them if they're unavailable. So you need to discuss things well in advance. At the clinic, you'll be speaking with the nurses more than your doctor, and sometimes messages are just relayed back and forth. If you have a particular concern, then you should raise it with your doctor. Schedule an appointment. Don't be shy about doing that. Each milestone is not a given. Most of the milestones are preceded by drugs, scans, and waiting. So you need to become an expert in waiting. What's the rationale for educating yourself on the milestones? Obviously, having a basic understanding of an IVF cycle is very helpful because you have a better idea of when you need the doctor's input and you can schedule an appointment. Knowledge also helps to alleviate stress, to know why you are doing something and why perhaps other people are doing something different. If you do know other women cycling, the tendency is to compare and you'll start to wonder if they're doing it better. So it's important to educate yourself on why IVF is different for a 40-year-old, so you don't feel as if you're not doing something that you should be doing. The protocol, meaning the drugs and the length of treatment, is likely to be different. Often with IVF, when you ask a ton of questions, you can be shut down sometimes with a response to simply follow the next set of instructions and not think too far ahead. That's good advice from the doctor's perspective, in the sense that the priority is to have a patient follow instructions and take the correct dosage. They don't want you getting confused. But it may not be enough for a 40-year-old, because a lot is riding on the treatment. The more you risk, the further you fall. So to insulate yourself, you need to understand what it is you are doing. A 40-year-old needs to know that their treatment is tailored to them. If a specialist simply says, "Don't Google," that's pretty unhelpful these days. It would be better to explain that Google tends to cater for the majority of patients who are not 40-year-old patients, and you are seeing me because I have this special expertise and clinical experience treating 40-year-olds. This is what I do. So what are the parts to an IVF cycle? Well, the first is pre-treatment. Now, by pre-treatment, I mean the period months before the start of any IVF cycle. Your follicles actually start growing 4 months before the IVF cycle. The IVF stimulation drugs only work on the last 2 weeks of follicle growth. When you see a fertility doctor, you should raise the question at your first consult of pre-treatment in terms of whether you should be taking supplements. You need that lead time for supplements to work if you're going to take them. At my first consult, it was the first time I'd heard of DHEA and coenzyme Q10, which both do good things to your egg cells, apparently. DHEA is dehydroepiandrosterone, which has taken me a long time not to stumble over. It's a mild androgen, a male hormone, which both men and women produce naturally, and it is essential for healthy eggs. It's a supplement, not a drug, so it has not been tested in pharmaceutical-funded trials. Studies are limited in that the sample sizes are small, but those studies suggest that women with low egg reserve, if they take DHEA months before IVF egg collection, improve the number of eggs collected. Coenzyme Q10 is a naturally occurring antioxidant which declines with age. It's a nutrient for the battery of your body's cells, the mitochondria. Again, studies with small samples show people taking antioxidants have better success rates. The upshot is that supplements may be beneficial in the dosages advised by your doctor. In high dosages, you don't know how supplements interact with the IVF drugs, so you need to follow your doctor's advice on supplements, which ones, if any, and in what quantity. Thank you for watching Making Babies in Your 40s. Would love to know what you think and what you would like covered. Please leave your comments and subscribe to my channel. See you next time.